All right, well, welcome everyone to my lecture. This is a preview of a lecture I'm giving at a conference coming up this week. This lecture is on how to be an ETCO2 Pro. I'm Dr. Jesse Shrieky. Up front, as far as financial disclosures go, I have really none to disclose. I do have a slight intellectual disclosure, and I run a website, www.reviewsedem.com. And this is a not-for-profit website. I post informations and other reviews there. So I guess still, there's no financial disclosures. In this lecture, I want to go through 5 take-home points about ETCO2, its capnometry, and capnography. First, ETCO2 provides breath-to-breath ventilation info. Second, it provides information about the actual respiratory effort. Third, it helps aid in diagnosis of respiratory distress and the severity of respiratory distress. It provides real-time feedback on treatments given. And lastly, it detects shock. Where you see the yellow are the important slides to remember. To start off, we really have to understand where CO2 originates from, and we're going to go into a lot of detail about the Krebs cycle. All right, just kidding. I wouldn't do that to anyone. We have to go back, though, a little bit and know some details of ETCO2. So how is ETCO2 measured? Well, there are 2 major ways. The first is side stream sampling, and that's when in our tubing connected to our oxygen to our patient, we have another little tube that we can add on, and we've usually seen that as the nasal cannula, where a small amount of gas is sampled and then sent to a detector. Or we can have mainstream sampling, where the actual detector is placed in line with the rest of the tubing. Some advantages of the side stream tubing is that it's lightweight, but the disadvantages of that are that there are little delays in the actual measurements, and it's about 2 to 3 seconds. You can also get secretions and condensations in the tube. You might get air leaks, which will dilute the sample. You can also get high respiratory rates and water vapor that may falsely elevate the ETCO2 reading. So with these, you frequently have to recheck your setup. For mainstream, the advantages are that there's no delay and you get an instantaneous readback. There are a few disadvantages, though, that it does increase the dead space. And while this may be minimal, it's still an increase. It can only be used in intubated patients. It might kink the tubing because it's a heavier detector in the main line. And water vapor here can also falsely elevate our ETCO2 readings, but only by a small percent. So in comparison of mainstream to side stream, mainstream is probably a little more accurate, but clinically, I'm not sure how real that difference is going to affect us. Both, however, accurately reflect real-time changes in our patient in front of us. ETCO2 may underestimate the values of CO2 when PaCO2s in our blood gas are pretty high, at least greater than 60. However, ETCO2 is very accurate in the range of 30 to 55. But at some point, all these need to be verified with an ABG. Now to get on to our take-home points. So the first point, that ETCO2 gives us breath-to-breath ventilation information. That's real-time feedback right in front of us. And that can be looked at in 2 different ways. First, in the capnograph that we see in front of us over a matter of seconds, or you can do an additive range of all of these on machines and look at a trend over minutes to hours to see how your end-tidal CO2 values are going. And because it's breath-to-breath ventilation, it's real-time information. Think about how powerful that is, and think about how much information that gives us, looking at both the number and the graph. It's like an EKG for the lungs, and you wouldn't want to see an EKG like this, would you? How about normal values? Well, normal PaCO2 values from a blood gas are about 35 to 45. Normal end-tidal CO2 values are about 30 to 43. Normal venous carbon dioxide partial pressures are about 47 millimeters of mercury. And here in Phoenix, at sea level, those numbers are accurate. If elevation changes, those might change as well. But under normal conditions, the difference between the arterial blood gas and the end-tidal CO2 is only about 2 to 5 millimeters of mercury. Now let's pause here for a little physics warning, because we're going to talk about some physiology. And the physiology we're going to talk about is ventilation and perfusion mismatch. Now, V is obviously for ventilation, and P should be for perfusion, but in physics, we talk about flow. And because we're using flow, physics uses the letter Q. So therefore, we talk about a VQ mismatch. But if you want to substitute P instead of Q, then go for it. All right, now we're going to do pulmonary physiology, but don't worry, we're going to do it the emergency medicine way. So let's think about an idealized alveoli and capillary and where they meet. We start with taking in oxygen and we breathe out CO2. And we do about 4 to 6 liters per minute of this. And that's our ventilation. On the other side is our cardiac output, or perfusion, and that's also about 4 to 6 liters per minute. And as blood goes from the venous to arterial system, it passes through the capillary. As oxygen traverses and comes out as CO2, it goes through the alveoli. And this is where gas is exchanged. Anything that doesn't go through the alveoli, we call dead space, and anything that doesn't go through the capillaries, we call a shunt. So we know that ventilation is about 4 to 6 liters per minute, and cardiac output is about the same, which makes our normal ventilation perfusion, or VQ ratio, about 1. Now, in reality, our actual ventilation perfusion ratio is about 0.8, with a little more perfusion than ventilation. But for the purposes of this lecture, we can just think about it as 1, and both of them being about equal. All right, so like we said, anything that doesn't go through the alveoli is dead space because there's no CO2 transfer there. So what makes up that dead space? Well, we have anatomic dead space, like the bronchi and the trachea, because no CO2 is exchanged there. We have alveolar dead space, and then we have mechanical dead space, say on a ventilator or endotracheal tube. Now, alveolar dead space is where the disease change occurs. Our normal tidal volume is about 500 mLs in the normal person, or about 7 mLs per kilo for the adult, and 10 mLs per kilo in a child. Dead space is about 30 to 40% of our tidal volume, so approximately 150 mLs in a normal patient. Now, there are cases where this ventilation and perfusion will be mismatched. So we can have cases where the alveoli are perfused but not ventilated. And I would encourage you to pause the video here and think about what sorts of clinical cases this would occur in. Well, that would be things like large mucus plugging, a main stem intubation, or atelectasis. There will also be cases where the alveoli will be ventilated but not perfused. Go ahead and pause the video again and think about what cases this might be. Well, you might see pulmonary embolism, Certainly cardiac arrest would not perfuse, and any kind of hypovolemic shock. All right, now that we understand the physiology, let's go through what the normal capnogram or graph looks like. Here's our axis with end tidal CO2 being in the vertical plane and our time being in the horizontal. The dotted line represents our normal end tidal CO2 of about 40. So in the first phase, we have expiration, and that's all dead space, so there's not going to be any CO2 there. The next phase of the capnograph is a rapid rise where we have mixed air and CO2 as we approached the end tidal CO2. The third phase is the plateau phase. Now we've reached the end of our tidal breath and we should be getting all CO2. This is where we approach our maximum value. And then as we take a breath in, we rapidly breathe and get the CO2 back down to 0. And in between the phase 2 and phase 3, we have this angle. And this angle will represent VQ mismatch. And this starts to give you the idea of how powerful these capnographs look and what kind of information they can give us. The other angle is really by rebreathing CO2. And you can look at this narrow capnograph, and this is what we would expect in the normal patient. It's kind of like riding a thin little horse. How about what happens in a VQ mismatch? Well, again, we have our end tidal CO2 of 40 millimeters at our max. And we're going to have expiration. And then we're going to have phase 1, the rapid rise, reaching our plateau, and then inspiring again. Here now, notice the angles have changed. Now there's a VQ mismatch. And on the other side, there's also some rebreathing of CO2. Now it's like you're riding a fatter horse, and those angles are pushed out. And we're going to look at this in a little bit and see how it relates clinically to our patient. One last capnograph pattern that we should be aware of is when you have this sharp pigtail as it goes up. And this is representative of poor lung compliance, as lungs are getting squished. Now this could be from pregnancy, from just poor lung compliance overall, or from a morbidly obese or Pickwickian patient. All right, our next really important point is that end tidal CO2 describes respiratory effort. And now that you know what to expect on the graph, we can look at those values. Here we see again the normal capnogram with our plateau phase reaching about 40. But what happens if we have hypercapnia or hypoventilation? Well, now our plateau phase will be much higher. And so now we have our capnograph giving us increased values. I would encourage you to think about what clinical cases can cause this and pause the video. Well, things that can cause this are overdose, head injury, seizures, or really anything that increase perfusion, like an increase in blood pressure. Shivering or tremors, as we have increased metabolic activity, can also do this. Bicarb can actually do this as well by giving an amp, or tourniquet release where you'd have a lot of reperfusion. On the other side, you may see hypocarbia or hyperventilation, where we were much lower than our max of normal 40 millimeters of mercury. And that can be from acidosis, hypothermia, decreased metabolism, or asthma, COPD. And this would be helpful, especially in the patient with a normal pulse ox, to see the severity of their disease. Our third important point here is that end-tidal CO2 can help us diagnose the cause of our respiratory distress. And to do that, we're going to look at an idealized alveoli. Actually, 3 of them. And we'll look at the first one. Now, notice that our end-tidal CO2 from our venous phase, as we recall, is about 47. And as that perfuses into the capillaries and then goes into the alveoli, we're going to get our exchange of gas and get our PaCO2 in those 3 alveoli. The middle alveoli we're going to talk about as being normal, remembering that at normal, our ventilation and perfusion aren't mismatched and are about the same. So our PaCO2 here is going to be 40. In our next alveoli, we're going to give it COPD. So it's going to have an obstruction to outflow. Now the VQ will be mismatched, and the ventilation will be much less than the perfusion. Now, because there's so much time spent around the capillaries, our PaCO2 will actually probably be a little bit higher. It'll be about 45. And lastly, let's give the third one a pulmonary embolism, so we have no perfusion. Well, again, the VQ will be completely mismatched, and there won't be any perfusion. So our PaCO2 here will be 0. If we were to graph these on a capnograph, you'd see the following. Now, remember, for A, we'd have our normal alveoli, so that will give us the typical curve and go to about 40. In bronchoconstriction, like COPD or asthma, you'll have increased work of breathing and making it harder to get that CO2 out, so that VQ mismatch angle will increase. Additionally, you'll see the plateau phase rise up a little bit higher than the normal, again because of the venous partial pressures of CO2. And in our last alveoli with a PE, you'll see lower than normal values for our capnograph, because not all of them can be 0, otherwise that would be death. If we overlay these, you'll see the differences between the different capnographs, and this will help us diagnose the cause of respiratory distress. So let's try diagnosing the cause of respiratory distress. Here's a tracing of a patient and their end-tidal CO2. Notice we don't have our classic box shape. What disease can you think of that gives us poor oxygen delivery, so it's harder to get the CO2 out? You have poor contractility, which lowers our plateau, and we have less than our normally expected end-tidal CO2. And finally, decreases afterload, making the end-tidal CO2 harder to get back in. Well, that's CHF. And this graph is typical of CHF in a patient on a capnogram. While this may not always be the case in CHF, if you do see this, you should highly suspect CHF. We can also diagnose other things. Let's look at this capnograph. Say we see this in a patient who'd been intubated about 40 minutes after giving rocuronium. What's going on here? Well, here we see what's called the classic curare cleft, where our patient starts to have a little bit of an inspiration and tries to suck back in that CO2 from its plateau. And you see that represented here as an inspiratory effort versus the normal classic pattern. We can also diagnose the respiratory distress in bronchospasm, and let's see how that happens. Now remember, this will apply to asthma, COPD, and bronchiectasis. Well, again, we have our normal end-tidal CO2 with our normal angles, but now let's add the work of breathing, like our accessory muscles. Because we can't breathe we have to use our accessory muscles, and that's going to take longer times to offload our CO2. What happens then? We get this rounded slope. Additionally, we have an upswing of our plateau. We call this the shark fin pattern of bronchospasm. An increase of this phase 3 slope occurs in a lot of diseases with airflow obstruction. The steeper the slope, the greater the severity of airflow obstruction, and those correlate, and we can see how severe the disease is. Additionally, we can diagnose the severity of the respiratory distress. In this 2014 study of almost 300 asthmatics in a pre-hospital setting, the end-tidal CO2 is measured, and the average is about 38. They then looked at the extreme ranges, those with an end-tidal of less than 28, and those with an end-tidal of more than 50. Because remember, asthma goes through phases. They noticed, compared to people in the normal range of about 30 to 50, those patients had worse clinical outcomes. A larger percent of them were intubated, a larger percent were in the ICU, and in that cohort, only those with an end-tidal CO2 in the extreme ranges died versus those in the normal range. So again, we can think about the severity of our disease. The next point is that end-tidal CO2 will give us real-time feedback on how well our treatment is working. So let's say again we have our patient with bronchospasm. And then after some time, they go back to normal. What happened here? Well, clearly we gave a treatment of albuterol, and we can see the effects of albuterol on our treatment to alleviate bronchospasm. We can also see how well our treatment is working with airway. End-tidal CO2 can be used to guide how quickly we ventilate a patient with bag valve mask, because we know harm is associated not only with oxygenation, but also ventilation. So we'll try to titrate our end-tidal CO2 to between 35 and 45. We also know that capnography is the most reliable method to confirm correct endotracheal placement of our ET tube. The last point is that capnography helps us to detect shock. And for you guys and us on the front lines, that's important. Now, CO2 changes will affect the end-tidal CO2 dynamically, much better than in the stable patient, although the unchanging stable vitals are death. So we can use it to guide our CPR. Adequate CPR should generate at least 20 millimeters of mercury to sustain a good cardiac output. And that's probably an underestimate. Looking at outcomes of shock, end-tidal CO2 is very valuable here as well, because those with cardiac arrest and who have an end-tidal CO2 greater than 26 have a much higher probability of survival. On the other end, we expect a high mortality if end-tidal CO2 is less than 10 after 20 minutes of good CPR. And to help guide our resuscitation, a sudden increase by 10 or to 40 millimeters of mercury might indicate ROSC. We can also use it to assess the quality of our CPR. Look at this capnograph tracing over time. We see end-tidal CO2 going down. And as a new assistant comes on who's refreshed, that will go back up to normal values. So keep an eye on that end-tidal CO2 during your resuscitations to know when to swap out providers. Check out this end-tidal CO2 tracing, where here at the first point we have arrest, followed by at A transient rise in our end-tidal CO2. What do you think is going on at that transient rise? How about at B? Now we have a sustained rise in our end-tidal CO2. What's going on there? Well, in this case, an amp of bicarb was given, and as we said, that bicarb is transferred into CO2, and we can see that as an output on an end-tidal CO2. So don't let bicarb fool you as ROSC, because just like in B, ROSC should be sustained. But if you see that fall, think about the bicarb that may or may not have been given. And then there are lots of other uses for end-tidal CO2. In this study of DKA, they looked at end-tidal CO2 of less than 20 and more than 36, and they found those to have very good specificities and sensitivities for ruling in and ruling out DKA, respectively. Studies have looked at it in sepsis and found an end-tidal CO2 of less than 25 to be a very good marker for sepsis, severe sepsis, and mortality. It can also be used in fluid responsiveness, a sort of holy grail of resuscitation. If we see an increase by more than 2 millimeters of mercury, this can help rule in or rule out fluid responsiveness with a pretty good odds ratio and negative predictive value. In this 2016 study, end-tidal CO2 outperformed other markers, including pulse pressure variation. It can also be used to help in mechanical ventilation. So we can determine the actual alveolar dead space fraction, because remember, that's where change in disease occurs. And that dead space fraction can be looked at as a fraction of the blood gas CO2 as the total, with our numerator as the difference between the blood gas CO2 and the end-tidal CO2. And then we can follow that dead space fraction to diagnose disease in our mechanically ventilated patients. You could use it to diagnose PE, because certainly you should get a much bigger dead space if a large pulmonary embolism starts to occur that would cause hypoxia or hemodynamic changes. Because really, in a ventilated patient, a dimer just isn't going to help. We can use it in ARDS to diagnose and look at mortality, because an increasing dead space is directly correlated with mortality in ARDS, and it can be also used to wean patients off the ventilator. All right, let's wrap it up with some cases. Case 1. You're on your way to the ED and are celebrating an awesome intubation. As a pro of the end-tidal CO2, you notice this tracing. You see capnograph with a peak, 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 and then nothing. What's going on here? Well, our differential diagnosis might be a dislodged ET tube, obstruction of the ET tube, respiratory arrest, or equipment malfunction. And this is actually a tracing of me as I was breathing into end-tidal CO2 and then stopped it. All right, case 2. You're called to the scene of an ill person. He has a BMI of more than 50 and complains of shortness of breath. You see the following pattern on capnograph. What's going on here? Well, it looks like that shark fin pattern that we saw. And the differential for that, as we recall, is any bronchospasm, asthma, COPD, bronchiectasis, or some incomplete airway obstruction, maybe a tube that's kinked or mucus plugging. And lastly, case 3. You're managing an intubated patient with a really fast respiratory rate, and you notice the below capnograph. As the baseline increases, you see the 0 value as the bottom, but towards the end of the graph, 0 is not the starting point anymore, so we're rebreathing CO2. And remember, that's going to widen one of the legs of the graph. The differential here could be auto-PEEP in, say, an asthmatic, or a circuit problem. Let's go back to those 5 take-home points. First, end-tidal CO2 provides a breath-to-breath ventilation information, and that's really powerful. It provides information about respiratory effort. It aids in the diagnosis and severity of respiratory distress. It provides feedback on treatments. And it detects shock. So in conclusion, remember, end title's a picture, not just a number. Just like you wouldn't want an EKG with just a heart rate on it. But no one parameter alone can diagnose our patients, so we always have to start with a clinical history and a good exam and see how that correlates. Because all this will help with your patients, and you'll be an end title CO2 pro. Hopefully that was helpful and not too overloading for anyone. Again, more information can be reached at my website, www.reviewsineM.com. Thanks for listening.